Hi, good afternoon and welcome everyone. Thanks for joining the Center for Democracy and Technology and the eHealth Initiative for today's webinar discussing the release of the draft consumer privacy framework for health data. My name is Andrew Crawford. I'm a privacy counsel here at CDT. And just a few housekeeping notes to go over before we begin. This webinar is going to be recorded, and please remember to stay on mute unless you're speaking. Let's go on to the next slide. So as you can see, we've got a full agenda for today's webinar. We're going to kick it off with a welcome from the CEOs of both the eHI and CDT. Next, my colleague Alice Leiter from eHI will go over an introduction of the project. Then I'll take over and give a review and an overview of the substance of the draft framework, including definitions, protections that apply to the data sets, some of the exceptions that we've included in the framework. And then my colleague Alice will talk about the structure of the framework, the proposed models that were considered, some of the accountability mechanisms. And then we'll end with some next steps, and most importantly, how you can provide feedback to the draft framework. After all, the goal of today is to introduce everyone to the framework, release it, and seek your comments. So please don't hesitate to reach out with edits, comments, and suggestions after today's webinar. Next slide, please. So now I'd love to recognize Jennifer Kovich-Brodnik, CEO of eHealth, the eHI, and also Alexander Reeve-Givens, CEO of the Center for Democracy and Technology, for some opening remarks and welcomes.
Great, thank you so much, Andy. Appreciate it. I hope everybody's healthy and recognize this is a very difficult time, particularly for our colleagues in the healthcare sector. And those with sick family members right now, or just those of you working at home and watching children simultaneously. Thank you for taking time to be with us here today. I want to thank the dozens of experts who took time to participate in this process over the last 6 months, and particularly thank Alice Leiter, Andy Crawford, Michelle Richardson, who really worked tirelessly to make this all happen and make sure we had a really meaningful project throughout. eHealth Initiative's work has really centered around facing challenges in healthcare innovation, and the majority of our challenges over the years have not been specific technical issues, but rather issues related to sharing information. Who would have thought when we started this project 6 months ago that it would coincide with what is likely to be the greatest pandemic in our nation's history? And COVID-19 has really exacerbated these issues of information sharing and only made our work more meaningful, relevant, and urgent. Prior to COVID, people thought of health information as the information in their doctor's offices and medical records, or a list of medications that they took. If there's one thing that COVID has increased awareness about, it's the sensitive nature of health information and health-ish information that lies outside of the doctor's office. In the last 6 months, COVID has taught us a lot. That information collected on your phone can now reveal if you've been in close contact with somebody who tested positive for COVID. That travel apps can reveal if you visited a high-risk area. COVID's also revealed the value of demographic data. It's revealed that specific populations are more vulnerable to COVID-19, and it's been used very effectively by public health agencies to expand testing, provide intervention, reduce spread, and identify and ensure that vaccines are going to work for all different communities around the country. And everybody knows now that public health organizations want your test results. But now the public is also aware that there are a variety of other folks that want your health information. Teachers, care workers who do work inside your home, individuals who come into close contact with your children. There's a whole variety of folks that are interested in healthcare information and demographic information. COVID's really helped educate the public about what information is, but also raised more concerns about how this data is used. So what information on your phone can be shared and with whom? How do we identify these at-risk groups and at the same time make sure that we're not discriminating against them? And then who is checking to make sure that all of this is used appropriately and safely? All of these have been critical issues and questions. And back in February, when we first met and launched this project, consumers did not have a clear set of regulations that addressed all of these sensitive issues. And today, they still don't. The framework that we are releasing today is the very first at starting to address some of those questions and issues. The framework outlines the types of healthcare data that should be protected, protections that should apply, and exceptions to those protections. We've also proposed a model with accountability mechanisms. We do not expect that everybody's going to agree with everything that we're putting out there today, which is why your feedback, as Andy mentioned, is so critical. And your participation in providing over the next 30 days is of the utmost importance. We want to hear from you. Finally, I do want to mention that eHealth Initiative has done a significant amount of work over the last several months on social determinants of health and COVID-19, which I believe in the future is going to dovetail really nicely with the final outputs of this group. In closing, it's been a very challenging few months, but our work with the Center for Democracy and really been a match made in heaven. And I really want to recognize that. With their legal expertise and our health information expertise, we've created a really, truly complementary, productive, incredible group of experts. And I want to thank the team. And the icing on the cake has really been when Alexandra Reeves-Gibbons took over as CEO in May. She couldn't have arrived at a better. She's been such a staunch supporter of this work, and she's been invaluable as we've started to finalize this phase and think about what comes next. So I'm really delighted to introduce her and turn it over to her. Thanks, Alex.
Jen, thank you so much, and thank you to everyone for joining us today. And also adding to the list of thanks, the Robert Wood Johnson Foundation for the generous grant that has made the work on this project possible. As Jen mentioned, this process has benefited from the participation of a wide range of steering committee members. The group brought together over 60 participants from healthcare providers and technology companies, academics, and organizations that, like CDT, focus on privacy, consumer protection, and civil rights. We're very grateful for their participation, their counsel, and we're happy and excited to get feedback from all of you who are joining us now as well. CDT comes to this project because the issue of protecting consumer health data is becoming ever more important. Jen talked about the ways in which COVID has focused national and global attention on the many ways in which health data can be used. But even more generally, when we're thinking about wearable devices, health and wellness apps, online services, and telemedicine, all of these can have wonderful benefits for consumers, but they also collect enormous amounts of information that is deeply sensitive and largely unregulated. Data is now collected and held by many entities that are not bound by traditional HIPAA obligations, something we'll talk about a little bit in the introduction to this webinar. Some data, such as search history and location information, may not even appear to be health-related, but can be used in a way that implicates a person's health. As data is used in novel ways to create new opportunities, we feel strongly that that innovation has to be balanced against the risks of potential misuse or discrimination. In our view, protecting this information is a value add not only for consumers, but also for businesses who benefit when consumers trust their products and their services. So to that end, the draft framework that you'll hear about today raises the bar for corporate practices around the collection, use, and sharing of health-related data. For CDT, I'll say that one of the most important elements has been thinking creatively and moving beyond outdated frameworks that simply rely on user notice and consent. Today, it's nearly impossible for consumers to manage and understand the privacy practices for every entity that collects, uses, or shares data about their health. As consumers, as individuals, we know the realities of notice fatigue. Many consumers simply don't engage with them or really feel like they have a meaningful choice but to opt into a company's policies, no matter the terms. At CDT, we feel strongly that it's time to move past this approach and instead establish sensible safeguards that users and consumers can rely on. As you review the draft, you'll see our goal of creating clear standards that work for businesses, but ensure that consumers' data is used only in ways they would reasonably expect. To us, this is really important work, and it's important work that can't wait until we get comprehensive federal privacy legislation, although that goal remains tremendously important to us as advocates in this field. We need to have the conversations now to build momentum around best practices and to invite companies to join together in ensuring that consumer information is well protected and responsibly used. So again, I'm grateful to our partners for this opportunity, to all of the participants that have helped to shape this work product, and to our speakers today who are going to lay out a wonderful set of information, both to give background to this work and to walk through its details. As others have said, we view this release as the beginning of the dialogue, not the end. So please do watch this presentation critically. We're looking forward to your feedback and we want to hear from you. Thank you again.
Thank you so much, Jen and Alex. I am Alice Leiter. I am a Vice President and Senior Counsel at the eHealth Initiative. My background is as a health privacy lawyer, and it has been a tremendous honor to be part of this project and this team. I am going to give a brief overview of our project and the value that it brings, its value proposition, and then also provide some context as to why it's needed. And lending support to this, what we've heard about our fantastic team, my colleagues Jen and Alex did a very good job laying out the project overview. So I won't spend too much time on this, but I want to reiterate our thanks to the Robert Wood Johnson Foundation for the grant that made this work possible. To say again that this grant is focused on the issues inherent in non-HIPAA covered data and find ways to shore up support for that data. And specifically, our goals were to examine the regulatory landscape and identify the types of data that were unregulated or underregulated and what that meant for consumers and for companies, to think through, propose, and evaluate potential approaches to addressing, if not solving, this problem in the absence of comprehensive federal privacy legislation, and then set forth a preferred pathway for action across the healthcare industry. As you heard, in order to help us with this, we convened a truly extraordinary steering committee of experts that have helped us with this work. The full steering committee met twice, in February and in July, and it's been represented. There's a wide variety of representatives from all across the healthcare, technology, academic, and nonprofit space. The bulk of the work took place in two work groups. Those work groups we titled the structure work group and the substance work group. My colleagues at EHI and I led the structure process, and Andy and his colleagues at CDT led the substance work group. Both had robust participation from steering committee members and met 3 times throughout the spring. And the framework that you see today is a combined single work product of the 2 proposals that came out of both of those groups. You'll hear from Andy first on the substance, the privacy protections and standards that we propose put into place, and the structure section will give an overview of the model that we propose that framework take. Hopefully by the time this presentation is over, and certainly after you read in great detail immediately our full framework, the value proposition will be quite clear. But to just state it explicitly at the beginning, we see this work as bringing great value on a number of fronts. First, as Alex mentioned, we are all in support of an eventual piece of federal privacy legislation that is much more comprehensive than what we have now, that expands the universe of data that's covered beyond what is currently covered by HIPAA. But we also recognize that our work in this draft framework is not a be-all, end-all solution. It is merely an interim step that hopefully can serve as some sort of a model and certainly a bridge to this eventual federal new law that we hope for. It also significantly raises the bar for consumer privacy. It heightens the protections of consumer data that falls outside of HIPAA protections. It closes gaps in existing legal and regulatory coverage. And importantly, it shifts the burden of privacy risk, of the assumption of privacy risk, off of the individual consumer. It also benefits companies and organizations that would join our framework that collect and use health data. It gives organizations an opportunity to be privacy all-stars, to be proactive and forward-thinking in their privacy practices and stay ahead of the legal or regulatory curve, which has the added benefit of reducing both legal and reputational risk to those companies. It also has the potential to provide some greater compliant certainty to companies. As I'll talk about a little bit later, the current legal landscape is often contradictory, sometimes unclear. There are lots of gray areas, and we want to give companies the assurance that they're doing the right thing and meeting their obligations, both from a right thing to do perspective, but also from the legal compliance perspective. And finally, we see our work as bringing value to regulators and oversight bodies as well. It will allow Congress, the FTC, and state-level authorities to better measure compliance of the companies handling this non-HIPAA covered health data, and give these authorities a greater ability to enforce the privacy practices to which these companies will have publicly committed. And now the good stuff. It's always nice when you can put a face with a name. So here's your HIPAA hippo. You've heard us mention HIPAA a number of times, and my guess is that most of you are familiar with it. But just to do a little level setting, since we talk about HIPAA so much, HIPAA stands for the Health Insurance Portability and Accountability Act. It is the nation's primary and most far-reaching federal health privacy law, and it was originally passed in 1996 in an effort to improve the efficiency and effectiveness of the healthcare system. More health information was becoming digital at the time, in this law and its accompanying regulations were aimed to modernize the flow of information. Among other things, HIPAA required the creation of national standards that would protect sensitive patient information for being used or disclosed without the patient's consent or knowledge. And although the more important aspect of our work is what HIPAA doesn't cover, I wanted to start by talking about what and who HIPAA does cover. HIPAA applies to so-called covered entities. These are your traditional healthcare providers, doctors and hospitals, healthcare plans and insurers, and then for our purposes, the least relevant categories, but also covered by HIPAA, are healthcare clearinghouses. And the specific data that HIPAA covers is known as protected health information, or PHI. And that is individually identifiable health information, which is broadly defined to include demographic information and other information that relates to a patient's current or past health status. And that data that is HIPAA covered must be created, held, or transmitted by a covered entity or its business associate. A business associate is the kind of hardest to explain category, just because it broadens the scope of HIPAA beyond the easily understandable providers and plans. But a business associate is any entity that enters into an agreement with a covered entity to provide some sort of service on its behalf that involves the use of protected health information. So business associates, by virtue of the business associate agreements that they enter into, also assume HIPAA responsibilities and compliance obligations. But then the good stuff is what HIPAA does not cover. And that has been the focus of this project, as we've said a number of times, but remains kind of the most important underlying categorization. Data that is created or held by a person or company that is not a covered entity or business associate is not covered by HIPAA and does not have HIPAA protections. Also, data that is not individually identifiable is not covered by HIPAA and therefore does not enjoy HIPAA protections. And so again, this may be stating the obvious, but an individual, a consumer, is not a covered entity. And so information that an individual generates and stores on his or her computer, information that is uploaded into any one of these hundreds of thousands of health or fitness or nutrition or wellness apps, that information is not covered by HIPAA. Most frequently, the companies that store that data, the app companies, the web browsers that store health searches, those are not business, they're not covered entities, and they tend not to be business associates of covered entities. So all of that information falls outside of HIPAA protection. And so as you can imagine, between 1996, when HIPAA was born, and now, there's just been this massive proliferation of data that is created and held by individuals and companies and used and stored in all sorts of extraordinary ways, but that is not HIPAA covered, very much health data, very much sensitive, and therefore we find to be underprotected. HIPAA is the main game in town, but it's not the only law that applies to health data. So just very briefly, I wanted to run through a list of some of the other laws that do protect health data. We've got HIPAA that applies in the health system context. There are also the Part 2 regulations. These are federal regulations that apply to patient information held by federally funded substance abuse treatment programs. There's the Common Rule that governs federally supported human subjects research. There's FERPA, the Family Educational Rights and Privacy Act, that applies to educational records, and often there's health information and educational records. There are as many state laws governing health information as there are states. And so as you can imagine, there is a patchwork, is almost an understatement, of laws governing individual types of health data in ways that are often more stringent than HIPAA and in ways that often contradict with other state laws. It's important to mention the Federal Trade Commission Act, because the FTC Commission has the authority to address unfair or deceptive acts or practices in or affecting commerce, and that applies to company terms of use. And these health apps or fitness apps, if they violate their own terms of use, they're subject to FTC enforcement authority. And then there are the GDPR and CCPA. That's the General Data Protection Regulation out of the European Union, and the California Consumer Privacy Act. These are kind of the hottest privacy laws right now, and probably serve as an indication of where we'll probably go when we take up federal privacy legislation. They may not apply now, though, given their geographic scope, and when they are applicable, they can be both underprotective and overprotective. And for all of you visual people out here, I like this slide because it just reiterates what I have said in a more visual way. Over on the left-hand side of the screen, you see HIPAA-covered data that is in the traditional healthcare system with providers or plans and their business associates, information that constitutes protected health information. And you can see some of the higher level parameters of how that information can be used and disclosed. But over on the right side of the screen, this minimally regulated health data is what our framework really set out to address. And this is the information that is generated by a consumer and collected or stored or uploaded into apps or websites. You can see some examples here: your heart rate monitor, a Fitbit step, wearable devices, web searches, any wellness survey that's taken. That data is held by tech companies, and it really only is subject to the individual company data terms and conditions, and regulated by the FTC under this unfair and deceptive practices standard. And our goal is to help out the FTC by providing an intermediate layer of protection so that they're not responsible for policing the entire universe of non-HIPAA covered health data. And then I just want to mention that very often data that was previously covered by HIPAA leaves the healthcare system and then becomes non-HIPAA covered. Just because data once enjoyed HIPAA protection because it was in your doctor's office, once you take it out of the doctor's office, once you authorize the doctor to send it to your phone, your app, your whatever it may be that whoever it may be that you want to have your health data, it loses the benefit of its HIPAA protection. With that, I will turn it to Andy, who's going to talk a little bit about the harms that can come from a privacy violation and what we're trying to protect against.
Thanks, Alice. So hi again, everybody. I'm Andy Crawford, counsel at CDT. And before we begin diving into the substance of the framework, I wanted to first discuss some of the harms to consumers that come from privacy violations. So what are these privacy harms to consumers, folks like me and you, that our draft is looking to address? I thought it'd be good to use the example on the right of a reproductive health smartphone app to illustrate many of these points. So for those who aren't that familiar with reproductive health applications, these apps are used by millions of users. They allow users to log bodily functions, things like sex drive, they can log medications, and users can even log their moods. These apps also allow new families to input information about their infant, including medical data, including their name, the location where the birth occurred, and also if there are any complications during the pregnancy or a birth. So now that we've laid out a little of the information that some of these apps can collect, let's walk through some of the harms that can result from improper use of this data. Embarrassment is one that I think many folks can relate to. As I just mentioned, these health apps, especially reproductive health apps, collect a lot of sensitive data. And I think many of us would be uncomfortable if information about our sex drive, medications, and mood were used in a way that we did not intend for them to be used. There's also harm that comes from creep into other areas of life. Again, with the reproductive health app, it illustrates how sometimes this data is not only shared between the consumer and the app itself, but the apps can sometimes share that data with other parties, including sometimes with employers. That can have real implications for consumers' livelihoods and also even their access to healthcare. There's also harms that come from inaccurate data. To the extent that data is being used for diagnosis or health treatments, we definitely want that data to be correct. There's also discriminatory health treatments. When not appropriately used, these data sets can exacerbate existing biases in the provision of healthcare and treatment to folks. Additionally, there's a lack of autonomy. When data is shared with parties, especially for unexpected uses, consumers can quickly lose control over their intimate health information. And finally, and importantly, there can be harms that stem from lack of trust in technology and health services. New technologies hold great promise for us, for better health outcomes, even to help us get and better reach our fitness goals. But when this data is inappropriately used or shared, it can result in real harms to consumers and also a loss of faith and trust in new and promising technologies. Let's go on to the next slide. So let's dive into the substance part of the framework now. This was a large undertaking. As such, CDT and eHI each focused on specific sections as Alice laid out. We at CDT focused on the substance section. Within that, we're talking about the definitions, the rules, and the exceptions to those rules that apply under the framework. eHi focused on identifying the structures that would support that framework, and Alice is going to discuss a lot about that later on in today's presentation. Also, as Alice mentioned, we set up work groups. I want to just give another shout out to all the members of our steering committee and our substance work group who devoted a lot of time and effort into helping us inform this draft. So thank you again. Let's go on to the next slide. So with the help of the work group and the full steering committee, we at CDT really focused on 3 key aspects of this draft. Those are namely the definition of consumer health data. We call it consumer health information within the framework. Use, sharing, and collection rules and limits, and then appropriate exceptions to those rules. We did all of this with the goal to strengthen consumer privacy protections while also allowing, for appropriate use of consumer health information. The draft also includes provisions that deal with transparency. We've also included consumer controls, for instance, for consumers to access their data, to correct errors in their data, and even to move and port their data. There are also provisions around general data security requirements for entities that decide to embrace the framework. Let's go on to the next slide. So our draft goes beyond older models that revolve primarily around notice and consent. Specifically, our draft includes strong collection, use, and sharing limitations. And these are especially focused around secondary and unanticipated or unexpected data practices. Our model also borrows from some of the best concepts from our European and California colleagues. As Alice identified, those are some of the hottest privacy laws that lots of people talk about these days. And the users benefit from those heightened protections, sometimes even if their local laws haven't been updated to more modern data practices. Our draft aims to be consistent with the protections found in GDPR and CCPA and includes many similar consumer access provisions. Our draft is also designed to complement other frameworks while also filling gaps that some of those frameworks don't address. I've listed 3 and I'll quickly compare the Karen Alliance with our draft. And the main difference is the scope of the data that our draft intends to cover versus what the Karen Alliance proposal does. The FTC best practices for mobile health app developers, again, the difference really between ours, or one of the key differences between our approach and theirs is the scope of entities that the framework would cover versus the FTC model. We also looked at the Network Advertising Initiative's Code of Conduct. Again, a key distinction between our approach and theirs is both the scope of data that would be covered and also the scope of entities that would be covered. Let's go on to the next slide. So as Alice noted already, consumer health data can take many forms. Sometimes data is clearly health data. However, our data ecosystem, it's constantly evolving, and seemingly unrelated data sets can now be utilized to make extremely probative insights into consumers' physical and mental health. Data can be converted to health information based on how it's used. So what I've tried to represent here on this slide is a continuum of a host of different data sets that some appear health related on their face and some might not be, but I'd argue that what we are trying to get at here is that when they're used in certain ways, that data set can indeed be consumer health information. So I'll walk through the continuum starting at the left, data disclosed outside of HIPAA. As Alice mentioned already, what we're talking about here is literally your medical records, medical imagery that your doctor or your health provider had that you as the consumer have subsequently asked to be moved to an unregulated or a non-covered entity. Next is DNA. Think about consumer-facing DNA analysis products that utilize samples from consumers and then represent back very probative insights into that consumer's potential health conditions. Next, we've got data that's created by wearables, health equipment, and health apps. What we're talking about here are things like vital signs, performance metrics, and as I mentioned earlier, this can include reproductive health information as well. Moving down the continuum, we're starting to get into things that on their face might not appear to be health data, but when used in certain ways, definitely implicate consumers' physical and or mental health. Things like website browsing history. This is data created from other services and products. This can also include my participation in an online support forum for a chronic condition or disease. This can also include location information. If my location information reveals that I am a frequent visitor to a medical facility, especially one that specializes in certain treatments, a lot of information can be garnered from that, and insights can be made about potential conditions I might have and I'm seeking treatment for. Next on the continuum is data that's created by AI and advanced computer learning systems. What we're talking about here is insights from big data processing that confer health conditions and implicate consumers' health. And then finally, aggregated consumer data. What we're talking about here are data sets comprised of mainly traditional data brokers, entities that have large data sets about consumers. Let's go on to the next slide. So let's dive into the three most important elements within the substance of the framework, at least three of the most important. And over the next 3 slides, we're going to discuss the definition of consumer health information. Next, we'll talk about the limits around data collection, disclosure, and use. And then finally, I'll touch on some of the exceptions we've included within the framework. When it comes to the definition, we embraced a broad definition for consumer health information based on purpose and use of data. When we went about drafting this definition for consumer health information, we recognized that this data is sensitive and private. If disclosed, it could potentially be embarrassing and even enable various types of discrimination and harms, as I've noted above. So we embraced a two-pronged approach, the first prong being this purpose and use approach. This first prong recognizes that data can indeed be health data, even if it is used, or when it is used for those purposes, when it's probative to a user's mental or physical health, even if it appears unrelated on its face. We chose to go this way, and we chose to use this method in an effort to cover the vast data sets that I just discussed. We didn't want gaps in coverage, but instead we were looking for wraparound protections for consumers, regardless of format or the entity that holds the information about the consumer's health. This approach also gives us definitional flexibility. It's intended to be tech neutral and evolve over time. It's also intended to reflect modern data practices where data moves quickly, instantaneously. Data can be hard to track, and data can be fungible and interchangeable. This purpose and use approach allows for any data that is used for health purposes to be covered by the framework's definition. The second prong of our definition included in the draft is designed to identify data sets that always constitute consumer health information. To that end, this portion of the definition declares that certain types of sensitive information, sensitive data sets, shall always be subject to the framework, regardless of the content of their use, or the context of their use, excuse me. Let's go on to the next slide. So when it comes to data collection and use limits, currently consumers bear the overwhelming burden of protecting their privacy. Many privacy policies are dense. They can contain provisions that consumers miss or don't fully grasp. Alex talked about this already today. To help address this, we've drafted this section to permit data collection disclosure, and use practices that center around consumers' health information being used for limited purposes, consistent with consumer requests and their expectations. We also drafted this section so that data collection, disclosure, and use limits carry through to third parties. Consumers should be protected without having to take burdensome additional steps to monitor how their data is being used by third parties as well. Now, we know these limits on collection, disclosure, and use within this section are likely to curb some current advertising and commercial product development. We understand this approach is more stringent than others, especially other voluntary frameworks and even some legal standards. But we believe this health data warrants the protection. It's just that sensitive. Let's go on to the next slide, please. So the third key component under the substance portion of the framework that we've included is limited exceptions. These are exceptions to that permit the collection, use, and sharing of some consumer health information. So for example, under the draft framework, we permit research. Research can be undertaken with the approval of a privacy review board. It can also be undertaken utilizing de-identified consumer health information or aggregated consumer health information. Our framework also, of course, permits a consumer to consent to allowing their data to be used for research. We've included an emergency use exception when there's the risk of death or serious injury. And there are also security and product functionality exceptions. We've included these to ensure consumer-facing tech is safe and works as intended. Now, we understand there are several equities at stake with this data set, and we've drafted these provisions to borrow from some longstanding laws that really attempt to do this balancing the equities between individual privacy and societal benefits for the use of this data. We want to get this right, and that's why we're highlighting this as one of the three sections we'd really like folks to weigh in on and give us their feedback. Let's go on to the next slide. So this time, I'd like to introduce Devin McGraw. Devin is co-founder and chief regulatory officer for Citizen, which is a consumer health technology startup. Previously, Devin directed U.S. health policy and security as deputy director, health and information privacy at HHS's Office of Civil Rights, and acting chief privacy officer in the Office of National Coordinator for Health and IT. Devin also directed the Health Privacy Project at the Center for Democracy and Technology for 6 years, and led the privacy and security policy work for the High Tech Health IT Policy Committee. Devin's been a committed member to the steering committee that we've set up for this project, and also an active participant within the substance work group. I'd love to turn it over to Devin now to give her reactions to the project and the current draft.
Great, thanks a lot, Andy. I was really pleased to be part of this effort. Going back to Jennifer Kovich-Bordnick's comments at the beginning, I think that bringing together these two organizations in terms of expertise in health married with strong expertise in privacy is just a really powerhouse effort. In addition to collecting, reaching out to a really broad array of stakeholders during the process of pulling this framework together. Getting health privacy right is not easy. Having spent decades doing this work, it is enormously challenging. And one of the reasons why it's challenging, there are a number of reasons why it's challenging. It's data that is of the most sensitive quality, but it's also data for which we have a lot of great needs to be, frankly, using it and sharing it more robustly in order to improve individual and population health, to be able to reduce disparities, just lots of needs for health data. And when you sort of try to bring all of that together and figure out a way to both provide the strong protections for this data while also making sure that it's still available, that is a true challenge. And so I applaud the efforts of the leaders here, and also thank all of the people who contributed to it. Having said that, I think there's a lot of room still for public comment on these drafts. I've been sort of looking through the Q&As as this program has gone on, and there are lots of questions that people have, and I really urge folks to, when the framework is available, to take a look at it, to take a deep look at it, and to provide some feedback on it. Some of the things that I hope that people will comment on are, these collection and use limitations. I strongly agree that these are really critical to have in a framework. We cannot just rely on consent, even though consent should be strengthened, and that's addressed in the framework. At the same time, when you're talking about sort of limiting how people can collect, use, and share health data, you're essentially saying, well, you have to be quite careful, I think, to not limit it so much that you're actually impinging on the ability of health data to be really useful. On the other hand, you don't want the fact that we need to be using data more robustly to be the excuse for allowing sort of really unbounded collection and use of data in ways that consumers and patients do not trust. So that balance is a hard one to strike. And so I think paying really close attention to how those collection and use limitations work also with consent. Are we pushing people to put a lot into the consent because they've got collection and use limitations in terms of how they can use it downstream? I think is a legitimate question. Using data for algorithms is another aspect that is taken on by the framework that I think would be great to get some additional comment on. I actually think the framework takes a very good approach to it, recognizing the value that algorithms can bring to the healthcare space, but also the privacy and ethical risks as well. And then the last thing I'll mention is, how do you make sure that all of that you've got sort of downstream protections for of this framework as the data moves downstream, and is it appropriate to ask parties who agree to the framework or are bound by the framework to bind all of the entities with whom they share data? That, I think, is another legitimate question. So all of this is, I praise CDT and eHI for getting us to this point, and hope that people really will comment on it, because I think it will only strengthen the framework going forward. Thank you for the opportunity.
Thank you, Devin. And I think you highlighted why this is so important, but also why this is really hard work, and why we're soliciting more folks to weigh in, because we really want to try to find a way to get this right. But these are hard questions. And the three aspects that I highlighted and that Devin worked through too, these are some of the hardest parts of the framework. And we really do encourage folks to dive in, look at the text that we'll post, and come back to us with feedback and reactions. As I close out, I just want to thank everybody again who's helped with this. Thanks, Devin, for participating in this webinar too. And just emphasize to everybody again, this is still a draft. We're going to continue to work on this, and we look forward to receiving your comments. So I'll turn this over to Alice now, and she can talk about the structure of the framework.
Thank you, Andy, and thank you, Devin. It's like having a health privacy rock star in our webinar, so we're really grateful to you for being part of the process and being part of this webinar. I am going to talk about the work that our work group, the structure work group, did, and the proposed model for this framework that we have come up with. We, as I mentioned before, had a number of meetings of our work group, and we started off really with the world wide open to us. What are our spectrum of options for action? Should we do nothing and rely on our current system? Should we propose new legislation, or should we try something in between? And we relied pretty heavily on this spectrum of options that was actually developed originally by our colleagues at Manat, who had a grant from RWJ to do some landscape work that really set the stage for our grant. You see again on the left, we have the option to do nothing. Everybody agreed, fortunately, that that was not an option to us. And given that the far right, the new statute is our goal, what could we do in the middle that might take us beyond where we are now in a way that is both valuable and meaningful? You will be unsurprised to hear that we landed somewhere in the middle. We decided we wanted to go beyond some best practices or codes of conduct, just because those are out there already. Some of them have even been incorporated into company terms of service. And those just haven't really gone far enough when it comes to meaningfully increasing privacy protections for consumer health data. So we coalesced around the idea of trying out a self-regulatory program in healthcare. And that is, we are not the first group to have contemplated this. I will not say it was a non-controversial topic, but we made great headway in coming up with something that we think addresses some of the issues that other groups who've tried this or proposed this have come up with. And so we spent a whole meeting talking about what that actual self-regulatory program should look like. I won't spend a lot of time on this slide, but there are yet another spectrum of options for what a self-regulatory model might look like, from full government enforcement to a fully closed private sector system with market gatekeepers. And again, we landed somewhere in the middle. We agreed that we wanted to try a private membership model with a backstop of FTC support and enforcement. We proposed a consortium of healthcare and health tech leaders coming together to form a self-regulatory body that would operate independently, but would be aligned with and operate with the sort of backstop of the support of a federal regulatory agency. We will talk through the enforcement mechanisms and structures that we've put into place. We want the enforcement to be robust within the model itself, but also have the FTC backstop. And we wanted to make sure that this would be a voluntary membership model where compliance with the substance provisions that Andy just outlined would be voluntary. Now, it is my supreme honor to turn this over to Mary Engel to talk through the details of our proposal. Mary is currently the Executive Vice President for Policy of BBB National Programs. And until recently, she was the Associate Director of the Division of Advertising Practices at the FTC. So as you can imagine, she was a complete godsend to me and to our project, very active member of our structure work group, and really did the bulk of the work in helping me put together the proposal that she is now going to walk through. So with that, I'll turn it over to Mary. Thank you so much.
Thank you, Alice. And it was my pleasure to be part of the structure work group and this whole effort, which is so important. Just a little bit of background on myself. I joined BBB National Programs in February after 30 years at the Federal Trade Commission, where I worked primarily in advertising, but also in privacy, especially health and children's online privacy. In fact, I worked on the first health privacy case that the FTC brought back in 2002. Now I'm at BBB National Programs, which is a nonprofit organization home to more than a dozen independent self-regulatory programs in the areas of privacy, advertising, and dispute resolution. Among our programs you may be familiar with are the National Advertising Division, or NAD, the Children's Advertising Review Unit, or CARU, which operates an FTC-approved safe harbor under the Children's Online Privacy Protection Act, or HIPAA, and the BBB EU Privacy Shield, which is a co-regulatory program for companies transferring data from the EU to the US. Next slide. Here we go. Okay. So in the structure work group, we discussed a strawman proposal for what a self-regulatory program for non-HIPAA health data could look like. Self-regulatory programs historically have come in a lot of different flavors depending on the need of the participants, but given the sensitivity of the data at issue here, there was really consensus that there was a need for a high-touch program with all the bells and whistles for the highest level of accountability. And so specifically, the discussion was that this would be a pledge program where those who wish to participate would sign up and publicly agree to hold themselves accountable. And as I'll discuss in a bit, this is a really important point because it provides a hook for potential law enforcement, because it's deceptive to say that you're going to follow certain rules and not do so, just like it would be deceptive to have a misrepresentation in your privacy policy. So when participants enroll, there would be a rigorous onboarding process with conversations to ensure that the participant understands the program's requirements, what all the rules are that they're agreeing to comply with. There would be a lengthy checklist to ensure that their practices actually do comply with the program requirements, and hand-holding with the program staff to help them into compliance as need be. Subsequently, each participant would be closely monitored and assessed annually to ensure continued compliance, but there would also be random spot checks throughout the year to maintain vigilance. Participants would pay an annual fee to participate, and the fee could be scaled according to the participant's annual revenue to make it affordable. Next slide. Okay, so The hallmark of this program would be the rigorous accountability mechanisms built into it. After the participant is enrolled, there would be independent monitoring by program staff, but also a public-facing website that would accept complaints from consumers or other companies. The program staff would investigate these complaints and require the participant to develop a corrective action plan to mitigate any violations. If, despite the corrective action plan, the participant remained in violation, the program would provide for next steps, including consequences. And consequences for persistent or willful noncompliance could include suspension or dismissal from the program and or referral to the Federal Trade Commission or a state attorney general office. The possibility of FTC or state AG enforcement is really important here. The participant's pledge would constitute a representation in commerce that the FTC or state AG could find deceptive if it's not complied with. Moreover, this means that the FTC would not have to get over the hurdle of whether noncompliance with a given principle itself constitutes an unfair or deceptive practice under the FTC Act. Instead, noncompliance with the pledge would be the clear law violation. And although the FTC has limited resources, it typically prioritizes failure to abide by self-regulatory agreements. The program would issue an annual report covering its activities, so the incidence of noncompliance would be public, essentially a name and shame approach. And the program would also include a dispute resolution mechanism for resolving consumer complaints or complaints by another company that a participant did not comply with the program standards. Next slide, please. So although we sketched out the basic contours of what a robust self-regulatory program could look like, a number of issues remain to be fleshed out. And of course, comment is welcome on everything I just mentioned as well as these issues. One issue was the scope of the program, that is, who would be eligible to participate. There are a lot of entities that potentially may have non-HIPAA health data. Do we cover the universe or narrow it to certain segments? And if so, which segments? Another issue was whether the program should be run by a brand new entity created just for this purpose, or should it be run by an existing entity such as BBB National Programs? I have my own biased answer to that one, of course. A third issue was how to ensure that certification doesn't disproportionately favor certain types of businesses over others. For example, small versus large companies, new entrants versus established players, companies with one covered product or service versus many covered products or services. This is also related to the design of the fee structure to ensure that participation is available to all who want it, yet is set at a level that takes into account the program resources needed to support the certification. There was also discussion of the need to make the public aware of the program, and certainly participants could advertise the fact that they do participate and hold themselves out with a logo or a trust mark, but there was still a sense that a publicity campaign of some sort would be needed so that consumers would even know to look for the trust mark. Finally, there were concerns about the level of enforcement or accountability, how to ensure that it's sufficiently meaningful to encourage compliance, but not so stringent that participation feels too risky. So those were the highlights of our structure workgroup discussion, and I'll turn it back to Alice.
Thank you so much, Mary. I want to echo Andy in thanking our work group, thanking the steering committee, thanking Mary in particular. Truly none of this would be possible without the really active and deep engagement of so many. And I will say for the 100th time that this is a draft, that we are eager for your feedback. We are eager to involve as many of you as possible in bringing this across the finish line. And so we look forward to hearing from you. I'm now going to talk very briefly, since we're right up at the end of the hour, about next steps and how to submit feedback. We are soliciting your feedback. We will release this framework as soon as the webinar is over. We hope that you will read it and love it and tell us all of the things that you love and don't love about it. And then over the course of and that comment period will remain open for 30 days till September 25th or 6th, I believe it is. We will continue to review the draft with the steering committee and the feedback that we receive with the steering committee. And then once we have all of the comments in place and they've been reviewed, we will get to work drafting the final report, which we hope to release late in the year. The feedback mechanisms are available to you right now. You can email me, you can email Andy. We're always, as Andy says, happy to have our emails publicly broadcast. But there is also a website link on the eHI homepage where you can view the framework and where you can submit your comments directly from our website. We'll keep the comment period open till the end of February. You're welcome to comment overall on small issues. I'm sure that there are tons of questions that have already come in over the website mechanism or the comment box on Zoom. We will take those into account as well, but really we're hoping that we can funnel all of the feedback through our website and through our emails. So we thank you so much for your time and attention to this webinar, to reading the framework, to taking the time to tell us what you think. This is an ongoing process, and we look forward to being in as close or non-close touch with as many of you as possible. Transparency and the public nature of this was baked into our grant, so we're really happy to have reached this milestone.
I'll just reiterate what Alice said. Remember, this is still a draft, and we want to hear from folks. I know that there have been a bunch of questions asked, and since we're up against the hour, please utilize the many ways to reach out to me, Alice, and our organizations to ask us those questions directly, and we will get back to you. Don't hesitate to reach out with comments, suggestions, and edits. That's why we're doing this. We're really excited with the amount of folks that are interested in this, who remain interested, and who want to see us strive to get this right. So thank you in advance for your help. And I'll just take one final time to thank our partners at eHI, our friends of the Robert Wood Johnson Foundation, everyone who participated with the steering committee and the work groups, and thanks to everybody for joining us today.